Greetings, I'm Dr. Kim Yongjin. Today I'm going to talk about the clinical cases using Osstem's Ossbuilder, which is a customized titanium mesh. I've prepared a lot, so please look forward. Let's look at my cases. This is the first case. I removed the 6-unit bridge in the lower. I placed 2 implants on the canine area on both sides along with GBR. This is pre-op panoramic image. This is PA. As shown, because of severe periodontal disease, you can see a lot of alveolar bone destruction. This is pre-op clinical photo. The soft tissue condition is not really bad, and I planned for immediate implant placement after extraction. This is occlusal view. Let's look at CT image. Number 43, you can see buccal bone defect. Number 33, you can also see buccal bone defect. If you compare, the buccal bone defect in number 43 is not that extensive, however, it is in number 33. In the previous lecture, I talked about how the defect size can affect the membrane of choice, because if the defect is huge, it will require some space maintenance capability. I decided to use the Ossbuilder in number 33, and for number 43, I used the resorbable membrane for GBR. Because it is immediate implant placement, soft tissue is lacking. I chose non-submerged transmucosal GBR for both sides. Let's look at the surgical clip. Extraction is being done. Because of severe periodontal disease, there was a severe mobility and extraction was not hard. Flap was detached, granulation tissue was removed thoroughly. In number 33, there were extensive amount of granulation tissue and they were removed. Drilling was done. Taper kit was used. 4.0 by 13 millimeter implants were used on both sides on number 3. Sandwich technique was chosen. From the symphysis area, autogenous bone was grafted using autobone collector, which is a drill dedicated for autogenous bone grafting. I used autogenous bone and xenograft to do sandwich technique. In number 33, you can see that anchor is connected. As mentioned earlier, Ossbuilder is not directly connected to the implant, and there is a middle component called anchor. It is connected to the anchor first. The bone graft is done. In order to cover the bone graft, Ossbuilder is used. On the left side, sandwich technique was done for bone graft. The defect form encompasses the buccal and proximal area. I chose 2-wall augmentation type Ossbuilder so that proximal area can be covered with the proximal wing. I used a 5mm healing cap to fixate the Ossbuilder on the implant. GBR was done a transmucosal way. On the right side, the defect size was not that big and it was placed sufficiently within the bone envelope. And I used a resorbable membrane called Ossguide. I formed a hole like this, and this is where the healing abutment is going to be connected. Before bone graft is going to be done, Ossguide is fixated on the implant using healing abutment. Membrane is lifted. Around the implant body, I'm going to use the autogenous bone that I've harvested using autobone collector, and then on top, I'm going to use a xenograft. I'm going to cover the bone graft using the membrane. In order to fixate the healing abutment and the healing cap, which was used to fixate the Ossbuilder, I'm going to do primary closure. In the case of lower, gingiva is thin. After you use Ossbuilder, in order to cover Ossbuilder, in a lot of cases, Osguide is used. This is post-op CT image. As you can see in number 33, in other words, lower left canine area, you can see that Ossbuilder is doing a good job contouring the labial bone in an ideal way, and bone graft is positioned below that. In 43, the defect amount was not significant and you cannot really see the bone graft material. This is post-op 14 weeks. This is how it was healed. As mentioned, non-submerged GBR, if you do that on the buccal side, the keratinized gingiva can be preserved. Vestibule depths can be also maintained, therefore soft tissue aesthetics is very excellent. Ossbuilder was not exposed and soft tissue healing occurred nicely. On the right side, a resorbable membrane called Osguide was used and therefore secondary surgery was not necessary. However, on the left side, I needed to remove the Ossbuilder, so I slightly opened the flap. If I had used conventional titanium mesh, I would have had to open flap extensively because I had to use bone screw or bone tack to fixate the titanium mesh, which I would have to later remove. However, in the case of Ossbuilder, when you remove it, you don't have to open flap extensively because Ossbuilder is fixated just with healing cap. I made a small incision on the crest. I removed the healing cap, and then I detached the flap towards the buccal side. I removed Ossbuilder and removed the anchor which was fixating the Ossbuilder as well, and used the conventional healing abutment and did suture. You don't need to open flap extensively. After Ossbuilder is removed, this is CT at post-op 14 weeks. As you can see, 43 and 33, you can see buccal wall has been formed nicely. Contour is very nice, especially in number 33. The buccal bone defect was quite extensive. However, Ossbuilder was able to regenerate the bone and in the desired contour. This is a CT scan of number 33. If you compare pre-op, post-op, and 14 weeks later, after Ossbuilder is removed, you can see that bone has been regenerated. The defect was very extensive. However, with Ossbuilder, you can see that bone has been regenerated with the desired contour on the buccal side. This is a second case. This is a case where it was used in the posterior area. Some may wonder whether Ossbuilder can be used in the posterior area, and this is the case for you. 42-year-old male patient. This patient received extraction of number 46 and 48 in a different dental clinic, and transplantation was done in number 46. However, the prognosis was not very good. You can see that there's bone loss around it, and mobility was the chief complaint of the patient. After doing many inspections clinically, I decided for extraction. This is pre-op CT. As you can see, there's a huge defect on the buccal side. However, the bone level on the lingual side is in good condition. After extraction, in order to regenerate the lost buccal bone, I decided to use Ossbuilder. I extracted, open the flap, check the buccal bone defect, and place the implant. After that, in order to regenerate the destroyed buccal bone and to provide support around the implant, I did GBR. Sandwich technique was done. Around the exposed implant, I used autograft, and on top of it, I used a xenograft. Ossbuilder was used to cover the overall bone graft. As you can see in this image, before bone graft, you can see that anchor is connected. After that, the soft tissue was lacking because it was immediate implant placement. In order to do GBR in a non-submerged way, Ossbuilder was fixated using healing cap. Primary closure was done. This is post-op panoramic image, CT scan. This is after 4 months after surgery, as shown on the left. Ossbuilder is not exposed and healing is done nicely. I opened the flap and removed the Ossbuilder. As mentioned in the previous case, you do not need to make vertical incision to remove Ossbuilder because healing cap is the only one that is fixating the Ossbuilder. Crestal incision and circular incision towards the adjacent teeth are only necessary to open flap. And I detached the soft tissue slightly and healing cap was removed as well as the Ossbuilder. You can see how the bone is regenerated below the Ossbuilder. You can see very favorable bone regeneration after that. I removed the anchor which was used to fixate the Ossbuilder and connected healing abutment and did suture to complete the secondary surgery. This is the final prosthesis. After final prosthesis delivery, this is the clinical image as well as PA after final prosthesis delivery. You can see that the bone level is well maintained. Buccal to the final prosthesis, you can see that keratinized tissue as well as vestibule depth is well maintained. This is 2 years after surgery, the panoramic image. You can see that alveolar bone has matured a bit more. Let's compare the panoramic images. Before surgery, you can see extensive defect. Around the root, you can see extensive alveolar bone defect. After surgery, you can see that the Ossbuilder has formed the ideal contour. Vertically, the bone level is similar to interproximal bone. This is after final prosthesis delivery, and you can see that it is well maintained even after 2 years. In the 2 cases that I've mentioned, I'm sure some of you have already noticed, but the anchor was external connection type. There was a protruding area in the anchor. You position the connection hole, which is in the middle of the Ossbuilder, and on top of it, you would fixate using healing or cover cap. The length of the protruding area is approximately 0.8 millimeter, and therefore, in submerged cases, sometimes it would be exposed. Also, the healing cap, which is used to fixate the Ossbuilder, is connected to the threads of 0.8 millimeter protruding area. And it was not easy to do this. And there was possibility of wrong connection. A couple of years ago, in order to rectify this problem, internal connection type was introduced. I use internal connection type anchor system mostly. If you make a new order these days, I'm assuming that you'll be using the internal connection type anchor system. I'm going to give you a brief explanation. Cover cap is like this, and anchor looks like this. The connection is completely different. Therefore, the new cover cap or healing cap does not fit the old anchor. If you're going to use the internal connection type anchor, you need to use cover cap that is compatible with it. The length of the anchor ranges from 0 millimeter to 3 millimeter, and it increases by 0.5 millimeter. Another point you should bear in mind is that when you use internal connection type anchor, you need to use 0.9 hex driver. When you use external type anchor, you can use 1.2 hex driver. When you use the new internal connection type anchor, you need to prepare yourself with 0.9 hex driver. You also need to find the compatible healing cap or cover cap. As shown, if you use internal connection type anchor system and use cover cap, the area that protrudes above the Ossbuilder is only 0.3 millimeter. In the past, it was approximately 1.3 millimeter. The protruding area of the external connection type is 0.8 millimeter, and considering the thickness of cover cap, the protruding area was over 1 millimeter, and because of that, even if you do primary closure during healing process, cover cap frequently was exposed. To summarize, if you're going to use internal connection type anchor, you need to use the healing cap and cover cap that is compatible. As shown, the design came to be in order to minimize the soft tissue tension. If you're going to use it for the first time, if you have never used Ossbuilder system, I recommend you use internal connection type anchor system from the first time around. Because there's a difference in the area which sticks out, there's a less possibility of exposure. Let's look at clinical situation. It's different. On the right is external connection type anchor and the cover cap that is compatible with it. On the right is the internal connection type anchor and the cover cap that has been connected. You can see that the protruding area is significantly different. Let me show you a case that I've used the internal connection type anchor for the first time in number 16 because of severe perio disease. Extraction was done. I waited 3 months for healing. You can see that bone defect is very severe on the palatal side. After 3 months, you can see that soft tissue has healed well on the palatal side. You can see extensive and severe defect. Implant has been placed in ideal position on the palatal side. In order to get bone regeneration, I decided to use Ossbuilder. On the palatal side, the defect is significantly different from the defect on the buccal side. The biggest difference is the soft tissue on the palatal side is very thick, therefore it is difficult to maintain space with traditional membrane. In order to resist the compression coming from palatal soft tissue, the rigidity of membrane itself is very important. And rather than using PTFE membrane, I decided to use Ossbuilder. And I decided to submerge it. In order to minimize possible exposure, I used internal connection type anchor. You can see that it has been connected here. I did bone graft on the palatal side. After that, two-wall augmentation type of Ossbuilder was used to cover the bone graft in the palatal side. Cover cap was used for fixation. Primary closure was done, as mentioned earlier. Once you connect the cover cap with the internal connection type, the extruding area is only 0.3 millimeter, and therefore it is very easy to get primary closure of softer tissue and there's less possibility of exposure. This is post-op panoramic image as well as the CT scan. You can see that the Ossbuilder is contouring the ideal form of palatal bone and bone graft is positioned below that. The soft tissue on the palatal side is very thick and there will be a lot of compression. However, Ossbuilder itself is titanium mesh and therefore the space will be maintained in an ideal way. This is 2 weeks after surgery and 6 weeks after surgery. You can see that soft tissue is healing. It is not exposed. The cover cap itself is not even exposed. This is 4 months after surgery. Soft tissue has healed nicely. Ossbuilder cover cap are not exposed at all. I opened the flap and did secondary surgery to remove Ossbuilder. As mentioned earlier, even if you have submerged it, you don't need to make vertical incision. You can just make crystal incision, open flap, and on the palatal side, superior to the Ossbuilder, I open flap slightly more. I remove the cover cap and remove the Ossbuilder. You can see how the bone is regenerated. On the palatal side, sufficient thickness of bone has been regenerated. You can see that the bone has been regenerated in line with the Ossbuilder contour. 0.9 hex driver was used to remove the internal connection type anchor and healing abutment was connected, and that was how the surgery was completed. Before and after. So I've shown you cases where I used cover cap, and as mentioned earlier, there are healing caps dedicated for internal connection type anchor. When you want to use Ossbuilder in a non-submerged way, when you want to use internal connection type anchor, you need to use the compatible healing cap. The diameter of healing cap that is compatible with the anchor is shown. 4 mm and 5 mm healing caps are available. In this case, number 434, extraction as well as immediate implant placement was done. Because of severe buccal bone defect, the GBR was done. Rather than using external connection type anchor, internal connection type anchor was used. This is much easier to connect. dedicated healing cap for internal connection type anchor was used to fixate the Ossbuilder. This is much easier to connect because this is the internal connection type. Compared with external connection type, it is much more easy and stable. I have talked how Ossbuilder is used clinically and what kind of incision should be made when Ossbuilder is removed. I focused on my cases to explain about this. When you first use titanium mesh, you go through a lot of trial and errors. If there's exposure when you use titanium mesh, this can be catastrophic. However, in the case of Ossbuilder, this is a customized titanium mesh that has maximized convenience on the part of the surgeon. Therefore, you'll be able to use it fairly easily. And I believe there's very little possibility of complications because of this. Rather than jumping right into clinical practice, I believe you should first participate in lectures where hands-on courses are included, such as the master course. This is the end of my lecture. Thank you for watching.